Cuyahoga County Committee of the Whole for the purpose of reviewing the proposed 2012 to 13 biennial budget is called to order, and the clerk will please call the roll.
Calling the roll, Mr. Schron.
Here.
Ms. Conwell.
Here.
Mr. Jones.
Here.
Mr. Rogers.
Here.
Ms. Simon. Mr. Greenspan.
Here.
Mr. Miller.
Present.
Mr. Brady.
Present.
Mr. Germana.
Here.
Mr. Gallagher. Ms. Conley.
Here.
There is a quorum.
Okay. We know there are people signed in for public comment, but we're going to hold off on the public comment for just a few minutes as the staff is working at the podium area, and we will deal with a couple of other items before we do that. We'll go on to item number 4, which is the approval of the minutes. You have the minutes for the meeting of October 31st, 2011 in your packet. Is there a motion regarding those minutes?
Second.
Okay, it's been moved by Councilman Brady and seconded by Councilman Jones to approve the minutes of the October 31st meeting. Any discussion? Hearing none, all those in favor say aye. Aye. Any opposed say nay. The ayes have it. The minutes for October 31st are approved. We also have the minutes for November 1st, 2011 in your packet. And is there a motion regarding those minutes?
So moved. I moved to adopt.
Okay. Is there a second? Okay. It has been moved by Council President Conley and seconded by Councilman Schron to approve the minutes for November 1st. Any discussion? Hearing none, all those in favor say aye. Aye. Any opposed say nay. The ayes have it, and the minutes for November the 1st are approved as submitted. I would like to take just a couple minutes and review with my colleagues the procedure for our next meeting, which will be on Wednesday the 9th, starting at 2 o'clock. And at that meeting, I would like everybody to bring into the meeting 2 copies of your comments regarding the budget. And those comments could include an overview of your opinion regarding the county's general financial situation, any suggestions regarding additions or subtractions, and any other suggestions or approaches that you might want to advance. The reason for 2 copies is that 1 copy you'll keep in front of you to make your presentation, and 1 copy you will give to staff. And during the meeting, the staff will collect and reproduce them and produce copies of the packet both for the council and the public, so that everyone will have the benefit of everybody's suggestions. And then during the meeting on Wednesday, we will have a roundtable discussion in which each member of council will present their suggestions regarding the budget. I would make everybody aware that we are in uncharted territory. I've been involved in budget processes for 30 years, and what we're doing on Wednesday is stuff that's usually done in private meetings and caucuses and such things like that. But this is a new day, and we're going to work out the budget amendments out in the open. So that's what's going to happen on Wednesday. Also on Wednesday, we have on the agenda for for departmental updates if we need additional information. And I would, at this point, ask for Directors Mowry and Warner to be at that meeting on Wednesday, because we probably will need some supplemental information that you might provide. So, so that is the procedure for Wednesday. And at this point, I would ask the clerk to tell us who the first person is who is signed in for public comment.
The first person signed in for public comment is Patricia Morgan.
Okay, please come forward. We welcome you to the committee. The presenters have 3 minutes to address the council, and please proceed.
I'm the chair of the Community Advisory Council for Metro Health. All the members on the council are volunteers. The reason we volunteer is because we firmly believe that Metro is a vital community asset, filling a gap that no other hospital is willing to do. I'm here today to ask you to support Metro Health by maintaining or increasing the county subsidy for each of the next 2 years. As I said before, Metro is an invaluable community resource. It is one of the premier rehab hospitals in Ohio, maybe even in the country. Metro is nationally recognized in trauma care. It staffs its emergency room 24/7 with top-notch surgeons and nurses. Thousands of limbs and lives have been saved there. Metro is also nationally recognized in maternal fetal medicine and neonatal intensive care. There are many women with high-risk pregnancies that would not have delivered healthy babies were it not for Metro. The hospital has many outstanding programs that benefit the community. For example, the breast cancer screening program that focuses on uninsured and underinsured minority women, and the Partners in Care program that serves the most needy and is constantly, dramatically improving the management of chronic care for the poor. What I personally admire about Metro is its mission of being accessible to all people, and especially its dedication to the most vulnerable in our community. Thousands of uninsured people in Cuyahoga County would not have received care without Metro. And as you know, Metro has had a 36% increase in uninsured patients since 2008. The rapid growth of the uninsured is even more remarkable in the light of the continuing population loss in Greater Cleveland. I don't need to tell you that this increase is unsustainable without county support. The members of the Community Advisory Council are proud that some of our tax dollars go to the hospital. We ask you for your continued support so that Metro can thrive and continue to provide the needed resources for the health and well-being of our community. I thank you for your time and your consideration.
Thank you very much for your testimony. Before I call the next person, I did leave out one item on the procedural discussion, which is that in terms of presenting the overview and suggestions regarding any changes in the budget, that would be an opportunity for the administration as well. And if the administration has changes that they would like to suggest at this point, that we would encourage you to bring that forward in the same way with 2 copies, one for our staff, and we will have an opportunity for you to present that at the meeting on Wednesday. And and the person making the presentation can be whoever the administration chooses to do so. Thank you. Madam Clerk.
Okay. Also, a little clarification, if I may, Mr. Chairman, if the second copy could be given directly to Nikki, and then she will coordinate the copies being made for everyone. I would appreciate that.
Okay, thank you very much.
The next speaker who is requested to speak is Gloria Aaron.
Good afternoon, Ms. Aaron. Welcome to the committee.
Thank you.
You may proceed when ready.
Okay. I am here today representing CPAC, Community Partners for Affordable Accessible Health Care. We are a community-led group working to ensure all Cuyahoga citizens have access to quality health care regardless of their ability to pay. Sadly, our county continues to have high rates of poverty, higher than the national average. This, combined with the recent double-digit unemployment, which undercounts the true number of those unemployed or underemployed, has led to a significant growth in people without health insurance in our county. But at the same time as this growth in uninsured residents has occurred, state and federal cuts to charity care funding has put a real strain on every safety net hospital like Metro. Metro is our hospital, we own it. Provides much more charity care to the uninsured in Cuyahoga County than they have received. They receive funding to do so. We must ensure Metro not only remains a safety net hospital, they must maintain their community-based clinics so that our insured citizens will receive access to primary care doctors as close to home as possible. We understand Metro has seen an 8% increase in charity care over the last year, and as Pat has said, a 35% increase over the last 3 years, while funding from federal, state, and even county sources has decreased. CPAC is committed to keep fighting on the state level to change the HCAP formula so that hospitals like Metro will receive a fairer share, more representative to the charity care they are given. But in the meantime, we must deal with today's proposed budget. We realize the county too is suffering from large cuts in the health and human funding and are facing difficult budget choices. Oh, heck. Given these facts, we strongly recommend to county government look to increase Cuyahoga funding for Metro Health from the current 5% of Metro's budget closer to its historical high of 25%, or at least to the $95 million needed to cover uncompensated care at Metro Health in 2011, which I believe is really $130 million. To do this, we will not argue for cannibalistic budgeting where you take from everyone. Just please bear me 1 second.
You may take a moment to conclude.
We must deal with the human service levy, and we must do it now for the betterment of all citizens in Cuyahoga County. And that means taking it and changing it and upping the amount of that tax. It is unacceptable, and so we strongly recommend that the county council and the county executive put forth a human service levy that will at least maintain the current funding of Metro and other health and human services programs. We will support that tax increase, and we are willing as community leaders to go out in the community and educate people why this is necessary. Because our citizens and our uninsured and families that need these services the most cannot survive on the amount of the human service levy as it is. CPAC believes that everyone deserves access to quality, affordable health care, and we are confident that this council, that it really is a new day, and that you will share that concern and will support what we are asking, and in turn we will support you and work at whatever you need to get a health and human service levy passed. Thank you.
Thank you very much for your testimony. We welcome Councilperson Sonny Simon to the committee, and the clerk will please give us the name of the next presenter.
The next presenter is Dr. Ted Paran.
Dr. Fran, thank you for coming forward. Welcome to the committee. Please proceed.
Thank you, Mr. Chairman and other members of the council. I am Dr. Ted Paran. I'm the Associate Medical Director of Rosary Hall, the Drug and Alcohol Treatment Program at St. Vincent Charity Hospital. And I'm here to ask you to consider restoration of funding by way of the Public Assistance Fund. The decrease in funding that Rosary Hall has received this year from its annual Alcohol and Drug Abuse Mental Health Services Board grant of 42.7%. Let me tell you briefly about Rosary Hall. Rosary Hall is the addiction treatment program at St. Vincent Charity Hospital, founded in 1959 by Sister Ignatia, with a 59-year commitment to providing for the alcohol and drug abuse treatment service needs of the citizens of Cuyahoga County, regardless of their ability to pay. Rosary Hall, in addition to this historical commitment, has several areas of special expertise. Rosary Hall is the largest and highest expertise medical detoxification unit in the state of Ohio. It also began the first intensive outpatient treatment program in our region and has been a leader in both intensive outpatient treatment as well as in inpatient detoxification. As such, Rosary Hall is actually a referral agency with difficult detoxification patients referred by other publicly and privately funded drug and alcohol treatment programs in a 4-county region. When patients get really sick, they're sent to Rosary Hall. As a consequence, Rosary Hall has published more articles on treatment efficacy, as well as research articles in the area of drug and alcohol treatment than any other treatment provider in this county, and arguably more than any other treatment provider in the state of Ohio. We're the only provider of inpatient detoxification services that has the capacity to provide IV fluids, IV antibiotics, respiratory therapy, oxygen treatment, 24-hour registered nurse coverage, and 24-hour on-site physician coverage, since it's the only funded provider in an acute care hospital. As a consequence of that and our history and expertise, we're the #1 inpatient detoxification training site for the management of withdrawal skills in the state of Ohio. Why now am I asking you about this funding issue? Currently, we face an epidemic in both alcoholism and also prescription drug abuse, notably opiate and benzodiazepine abuse dependence, which present very difficult detoxification challenges. And at this time of a huge epidemic in prescription drug abuse,
Please take a moment and conclude.
we ask that the council consider restoring funding of the $425,000 decrease in funding that Rosary Hall is grappling with this year because of decreases in the Addis Board funding formula. Thank you very much.
Thank you very much for your presentation. I would bring to the committee's attention that we received packets of information on this issue that I would encourage you to examine. And Madam Clerk, is there anyone else who has signed in?
Mr. Chairman, no one else has signed in to speak.
Okay. Councilman Dan Brady has done yeoman's work as chairperson of the Health and Human Services Committee and has spent many committee hours helping us to become more knowledgeable about these important programs. And I now turn over the gavel to to Councilman Brady to run the hearing on these very important programs that we're going to hear this afternoon. Councilman Brady.
Thank you, Mr. Chairman. We'll be hearing from Metro Health first. In order that you have some kind of an expectation, we're looking for a presentation not to exceed 20 minutes by Mr. Moran. Welcome. And then we'll go to questioning by the committee. Welcome to the County Council once again. Mark Moran, and congratulations on the 175th anniversary of one of the most important institutions in Greater Cleveland. And we're prepared to hear your presentation for the new biennial budget.
Good. Thank you, Councilman Brady, Councilman Miller. I appreciate the opportunity to talk with you, and thanks to all the council today. We have a presentation. I believe we're set up to do this. No? Okay, we're going to go with paper today. So, first of all, let me recognize Metro Health board members who are here. The chairman of the Metro Health Board is Dr. Ron Fountain, who is here today. The vice chair of the board is Mr. Tom McDonald, and Polly Clemo is one of our longtime board members who many of you know. They are representing a board of 10 volunteer civic leaders who have, in many instances, spent a good portion of their life helping Metro Health continue to do its mission. I've also brought with me a number of executives from Metro Health, so if there are detailed questions that I can't answer, we can call them up. And then I guess finally, I'd like to thank Ms. Morgan and Ms. Aaron for their support, and I appreciate those comments. Let me, I'm going to stick diligently to the time that you've set for me, Mr. Brady, and I want to spend a few minutes on page 2 on the county environment, our performance in 2011, the 2012 goals and our budget target, and then our 2012 and 13 subsidy request. And I'll go quickly so that we stick to the time frame. Page 4 really does set the stage for where we are in the county. And the economic conditions are sobering. We can read about them in the New York Times or in the local paper, but the really key point is that there's been a profound increase in local poverty. Right now, Cleveland is the third poorest city in the country, with median income half the nation's. And last week, the Brookings report told us that 60% of Northeast Ohio's poor actually live in the suburbs. The recession is really clobbering us, no surprise there. But for us, unemployment, job loss, and poverty really limit access to care. And, so that really sets the stage for what we have to deal with. The next page, where the page number 5, where the page number is obscured, is what we call our blue dot chart. Each blue dot is an uncompensated visit to Metro Health. There are 200,000 blue dots on this page. The red dots are our locations. I think it's important to, you've seen this before. We don't need to spend a lot of time on it, but first of all, our mission is to provide health care for all, regardless of their ability to pay. That's Metro Health. Second of all, we were straining at 200,000 last year. We're up an additional 8% this year. We're looking at 217 to 220,000 uncompensated visits. And surprising to us, we were perplexed by this in the spring when we gave this to you, that 45% of the counties uninsured originate outside Cleveland. But when you see the Brookings results, now it's obvious that the reason they're originating from there is because that's where the poor are. Some fairly significant implications outlined on page 6. The need for the safety net, that's Metro Health, is more significant than ever. Our mission has expanded beyond our traditional network, which is the Cleveland city boundaries, and that we now are being called upon to serve poor from a vastly greater area. We have put in place urgent imperatives to meet the mission. We survived a financial storm in 2008, but the storm is chasing us right now, and you've seen that in our 2011 results. We're stretching our resources to do more. We're working to secure health coverage for the poor of the county. We're connecting patients to the medical home, and we're serving more patients. We're seeking to serve more patients with private insurance. Let's talk quickly about our 2011 performance, but I don't want to go into, I want to go more into the future. First of all, MetroHealth is recognized for its high-quality care. There are many awards. We've given you a snapshot of them here. All of our medical staff are on the faculty of Case Western Reserve. Our nurses have magnet status. We've passed the Joint Commission. We're gold on Get With the Guidelines, and we just got platinum for our pulmonary care on Friday. So we continue to be recognized for the care that we provide. On the next page, again, the number's obscured, but it would be page 9. Many of our volumes show continued resilience against the backdrop of unfavorable local economic conditions. It is not as if the loss of population has reduced our volumes. In fact, our volumes have continued fairly strong in the emergency department and in the outpatient area. And if you look at surgeries in the outpatient surgery area particularly, our average daily census has managed to stay stay pretty much flat, but I'll go into that more later. Page 10 is an important page. I think it's a page you've seen before, but I want to spend a moment on it because what it does is the pie shows you how our cost is really applied to patients. And you see that we have a number of Medicaid, about 35% Medicaid, about 24% Medicare, about 25% commercial. And this has been pretty stable for many years, and about 16.8% uncompensated care. That is care for which we receive little or no payment. Well, that amount this year turns out to be about $130.9 million in care at cost, at our cost, $131 million. How do we pay for that $131 million? Well, the County Health and Human Services subsidy pays $36 million of that. Ohio HCAP provides about $27 million, and MetroHealth's contribution, that is the margin that we earn on the Medicaid, Medicare, and commercial, goes into supporting the cost of care to the uninsured, and that amount is $68 million. The total, 130.9, is up $11 million this year. That's against the backdrop of a $4 million reduction in HCAP and a $4 million reduction in the county subsidy. MetroHealth is doing the heavy lifting for the uninsured of this community. Despite that, on page 11, you can see that our operations are break even. We're managing to maintain a small positive operating income line. And you know, this was against a budget of $25 million. This is September year-to-date numbers, so about 3/4 of the year. And we've asked ourselves, you've asked us, we've asked ourselves what happened. The charity care growth has been significant. The reduced subsidy and HCAP support has been significant, $8 million loss to us. On the inpatient side, our inpatients has shifted to observations, which is compensated at a much lower rate than inpatient. Our long-term care reimbursement has been cut. We have made an investment in faculty to make sure that we can preserve our fine faculty. And at the same time, some of our one-time revenue sources that we had really pushed hard to obtain in the last few years have been depleted, and we really we don't have those. So you can see, though, that we're moving from a level of 21 to 26 million, about what we had budgeted this year to a level of 1.4. And you can see why we moved there. We've taken a number of actions, many of which you've seen. We've reduced our staffing levels while maintaining quality patient care. We've reduced discretionary spending. We're rolling out our Access program, which is about ambulatory operations improvement and efficiency to improve utilization. We're launching inpatient short-stay units. We've expanded Metro Express and our ED capacity. We've consolidated our long-term care and skilled nursing unit. We're investing in ambulatory network growth, and we're refinancing our debt. All of these things are designed to make for a much stronger 2012 than the 2011 that we've experienced. I'm going to just touch on 13. We've invested $35 million this year to strengthen our capabilities in a number of different areas. We can come back to that if you would like. The following page, which would be page 15, is a snapshot of our balance sheet, of our capital structure. You can see the red line tells you what our bond covenants are, and you can see that we're performing well. We're secure against all of our bond covenants, but we are straining to meet the A bond rating benchmarks that we have. It's very challenging to maintain an A rating in this environment, and clearly that's something that we pay a lot of attention to. Moving forward to what's going to happen in 2012, what you can see is on page 16, moving from right to left, you can see the 2010 actual operating statement, our statement of revenues and expenses, going from net patient revenue of about $682 million to an operating income of about $23.8 million. This year, the projection that we gave you earlier in the summer showed almost $700 million in net patient revenue, $766 total operating revenue, but an operating loss of $6.3 million. And then as we've moved forward with all the actions I just talked about, what we're envisioning is, with the support of council and a $36.1 million county appropriation, we would have total operating revenue of about $780 million and an operating income of $10 million. And that $10 million is a level that we need to continue reinvesting in Metro Health. That $10 million supports a $40 million capital reinvestment in Metro Health. So our subsidy request. Our request is for $36 million on page 18, and I guess it is kind of important for me to emphasize that every dollar of the subsidy is dedicated to the mission. It goes to provide access to care for all, regardless of their ability to pay. The subsidy supplements the Metro Health charity care that we do because of the margin that we earn in our other sources of business, and state health care program support. And I guess the thing that I wanted, we went back and did a little bit of analysis and said, well, what's the value of supporting Metro Health to the county? And you see the chart on the left here that shows that from 2006, where each dollar of county support delivered about $1.70 worth of health care at cost to Cuyahoga County residents. The work that we've done on efficiency, the work that we've done providing more access to care, means that Cuyahoga County residents are now getting $3.55 in health care at cost from Metro Health for every dollar that you invest. So a significant source of value for the citizens of Cuyahoga County. Central to our request, and something that we've talked with each of you, I think just about each of you about, is what we call the Medicaid waiver. Metro Health is working with the state of Ohio to obtain a waiver to provide Medicaid coverage for 26,000 uninsured adults in Cuyahoga County, people who today are not eligible for Medicaid. The waiver would be matched by Metro Health's $36 million subsidy. Essentially, we would put that up to the feds, and the federal government would dedicate Medicaid funds, $64 million in additional Medicaid funds to Cuyahoga County. The waiver would extend a set of benefits to uninsured patients, health care, obviously, mental health support, pharmacy support, et cetera, et cetera. We have to define the benefit package that they would obtain. The waiver would be implemented through our medical home program called Partners in Care. Partners in Care has 14,000 patients, uninsured patients, enrolled in it today. It's proven, it's working, and we see that as the vehicle for increased coverage in the county. Our goal is to submit the waiver in early 2012 and have the program up and running by the third quarter of 2012. This is a significant infusion of funds. I was going to say enormous because it would be enormous for the Metro Health system. It's going to create additional health care. It's going to create additional jobs, and it's going to create additional economic development. It will have a significant impact in our ability to serve the community. So on page 20, it's going to be my conclusion, and then I'll stop and take your questions. We're really working responsibly towards a sustainable future, and there's certain aspects of sustainability. With this kind of increase in charity care, it really has, as I told you in May when I was here, it has really made safety net hospitals an endangered species. And we've managed to stay ahead of the curve, but just barely, right? Now, how are we going to be sustainable for the long haul? Number one, health insurance coverage for the poor of Cuyahoga County. We need to get more and better coverage, and we're working on the waiver with the state of Ohio. We've got to continually improve our quality of care, and we're making lots of process and technology upgrades to improve care. We've got to improve the efficiency of care delivery, and we've redesigned our ambulatory operations. We've expanded capacity in our ED. We've created short stay units. We're continuously improving what we do. We've got to shift to the ambulatory care setting. The entire healthcare industry in the U.S. is shifting from inpatient to ambulatory setting. We're working to do that too by expanding our network of accessible, convenient, efficient ambulatory centers. And finally, we've got to renew Main Campus. Main Campus was built in the 70s. One of our most recent buildings was built in the 70s. The ability of the Main Campus to support the Metro Health system efficiently will not last forever. We have a master planning exercise underway. I think ultimately the sustainability of Metro Health is going to depend on us having a new main campus that allows us to serve the community much more efficiently. So what I'm asking for today is I'm asking for the $36 million subsidy appropriation from the county, and I'm asking for your support as we reach to the state of Ohio and to the federal government for this Medicaid waiver. Thank you, Mr. Chairman. Those are my prepared remarks.
Thank you, Mr. Moran. To the committee, I know there are a lot of questions that people have today about the budget and about Metro. I would like that the committee come out of this hearing with as clear as an understanding as possible of exactly what Metro is asking for in their proposal, and this proposal to leverage money from the Affordable Care Act. We would not have succeeded, in my view, if we did not come out with a come to a clear understanding of this for our sakes and for the public's sake. as well. This is, I think, at least one of the most dramatic, if not the most dramatic proposals in the entire budget in terms of its implications. Having said that, I know there are other questions, and I'd like members to limit themselves to 3 questions at a time. I assure you we will come back to you as often as you would like to do that. So at this time, I'm going to open up the meeting to questions by the committee. Again, looking to get a clear understanding of Metro's proposal, knowing there are lots of other issues that are on people's minds that are relevant. So thank you, and Councilman Conwell.
Chair to Director Moran, I just have one question. You spoke about the bond rating. If the bond rating was lost, what fiscal impact would that have?
Immediately, probably not a lot. And I will say that because of our performance, we are refinancing we're actually about to conclude a refinancing that will actually reduce our interest costs by over $1 million next year. The issue would be in future financing, if we were to lower the bond rating, it could raise the cost of funds down the road. We don't have any future bond rating, we don't have any future bond issuance plans because we actually are working at about our full debt capacity right now. So the immediate impact would not be great. The long-range impact would be, could be somewhat significant. We're trying to avoid it, obviously.
Councilman Gallagher.
Mr. Moran.
Councilman, how are you?
Good. And I applaud you and your team on that idea of the leverage match. I think that changes the game that you have to deal with. And although I do believe your bond, your credit rating, needs to be buffered a little bit. I don't know how we do that because I would assume we're going to roll into writing bonds for the main campus, although I don't know what, and that kind of goes to my question. We're doing that ambulatory care center in Middleburg Heights. The dust up from that is I've talked to the mayor of Strongsville, Middleburg Heights, the council presidents of both cities, and no one seems to know how that happened. And I've asked them pretty direct questions. Your gentleman that was here before us, Health and Human Services, said in his testimony to us, because we asked, that's how you're going to start making money. When are these ambulatory care centers going to be up and running? What's the plan? And his testimony to us was 2014. And the board minutes that I've seen, 2014. And both were based on the fact that money was a problem. How did the ambulatory care center show up? Seemingly everybody's telling me they have no idea.
Well, I don't know about those people. So let me maybe go back and review the process. Since the middle of 2009, we have had a series of strategic exercises as well as start with those where we said that our coverage in the center city actually is quite good. The coverage in the areas outside the city is not as good, and that we needed to improve it. And so we did studies that looked at a series of areas where we actually are not providing much service, but where we could successfully provide service. And we looked at a set of areas where we seem to be doing the uncompensated care, but have less access to the insured business. And and we know what our mission is, and we're going to do that. But at the same time, we believe we should have access and the ability to provide convenient, efficient, high-quality care to these local areas. So we did that study, and then we began a process of developing a prototype site that would be efficient, low cost, and we did a series of real estate. We basically scoured Strongsville, Middleburg Heights, a number of communities right around that area as the first example. So in essence, we have been working on this for over 2 years. We have talked to the economic development directors in all of those communities. We have looked at many different sites, and by the time we got to earlier this year, it was clear that one site really stood out above all the rest that we had looked at, and so we made a commitment to the Middleburg Heights site. The funding for that was issued in early 2010 through the Build America Bonds program. We issued $75 million in Build America bonds. That is capital money, can't be used for operations. And it was issued with the specific earmark that it would go towards the development of our ambulatory network. So I have a hard time understanding how this could be a surprise, except for the specific site, which we did keep secret as a trade secret, a legitimate private matter for the system. And that I can understand would be a surprise, but that's how we have to acquire real estate, like anyone who's trying to acquire real estate.
Well, my concern was the testimony before this body and the minutes of the board state in 2014, and here in 2011 it shows up.
Well,
And here's where I'm going with that. This is going to happen in at least 3 more spots in Cuyahoga County.
Hope so, yes.
I would suggest that you do a way better job bringing in those communities in which all these satellite offices that you have, when you determine where you're going to go, please avoid the dust up that you started out there. It's not bad, but it could have been avoided with somebody just being a little bit more sensitive to what's going on and where it was and where it's going to. And we struggle with that here in the county. That's only my only concern.
Fair enough.
We understand that's what you need to do, and the spot in which you're going to, I understand the visibility makes sense to me. But it's kind of interesting that the people in the know didn't know.
Again, I'm surprised by that, but I will take your recommendation and become more sensitive.
And not a criticism, just the phone started ringing. That's for sure. And Mr. Germano will be taking that problem over. And it's not a problem, it's probably a good thing over there. What's your ETA on the main campus redo?
A little bit up in the air right now. As you know, we have a group called HOK working with us. They will go, they gave a briefing to the board probably a month ago. They'll go through the end of the year. We'll probably have another board discussion early in the new year. I think from my own perspective, without the science of how to build this, I think that we really are looking at a redo of main campus. Our ambulatory pavilion is fine. Our critical care pavilion is brand new, and it's in both of those buildings are in pretty good shape. But the rest of essentially the rest of campus is beyond its useful life, and I would say that has to be replaced between here and 2020.
Okay, that's all I have. Thank you. Thank you.
Okay, count that as 2 questions.
I'm done.
All right, thank you. Mr. Moran, if we could get back to the proposal, I thought those were important questions and inevitable questions. If we could get back to the proposal, if you could sort of try to walk us through the proposal for leveraging the federal dollars, who you have to go to, some of the hoops you may have to jump through, and I know John Corlett's been a big part of this, so
If I could punt that to Mr. Corlett, I think you'd get a better answer.
that would be fine.
Okay.
Thank you.
Thank you, Mr. Chairman. The process, this is a process that we began earlier this year. It's a provision in the Affordable Care Act that allows states or local parts of a state to expand Medicaid coverage early prior to 2014 to newly eligible groups. So in Ohio, that meant the possibility of expanding care to the uninsured adults between the ages of 18 and 65 who are under 133% of the federal poverty level. And so we sort of began this process first. Actually, the first place we stopped was we addressed this with the county executive's office because we wanted to make sure that they felt comfortable with us beginning to talk about it, because obviously you all and the county are integral to this. When we got sort of the green light there, we reached out to the state Medicaid director. So we met with the state Medicaid director and several of his staff this summer and said, here, this is what we're thinking about. You know, are you all open to this? Because the process is that Metro Health doesn't apply for the waiver, the county doesn't apply for the waiver, the state of Ohio has to apply for the waiver. And so we didn't want to go down a long path and then find out that they weren't comfortable with doing that. But we got the message from them that they were comfortable to keep talking about it. You know, they said obviously they'll have questions. As a former Medicaid director, I know there's nothing ever simple about Medicaid. It's probably one of the most complicated programs in existence. But they were willing to proceed with us. So since that time, we've had several more meetings with them, and basically have gotten the green light from them that, you know, if we can develop a good waiver proposal, a solid waiver proposal that addresses, you know, their issues, that they're willing to move it forward. And so our goal is to, during the first quarter of next year, to have a waiver drafted and have it submitted to CMS. That's the Center for Medicare and Medicaid Services. It's the federal agency that oversees the Medicaid program with states. And so we'd get it into them by the first quarter of next year, and then we would then work with the state to enter into what are usually negotiations. Waivers are kind of a product of negotiations between states and CMS. CMS, obviously, since they're paying the bulk of the cost of the program, cost of the Medicaid program, always have a lot of questions about, you know, what's the benefit package, you know, what are the eligibility standards, how are you going to determine eligibility, and all of those things. And so, so that would be our goal, is to have that into them by the end of the first quarter, and then work with them to get it up, get it approved, and then be ready to start putting it into operation in the third quarter of next year. I think, you know, some of the issues that we'll have to work out with them, you know, key issues like, you know, what is the benefit package? Because under the Affordable Care Act, it's not a benefit that's identical. It's not identical to the Medicaid benefit. It's referred to as a benchmark benefit. So it doesn't necessarily include all the things that are included in the Medicaid program, but it would include some things that are really important, like the pharmacy benefit. I think that for our patients would be one of the most dramatic benefits for them, is to have a pharmacy benefit covered. So that's one piece. It would include things like transportation, durable medical equipment, things like that, that today, for a lot of our low-income patients, those aren't necessarily services that Metro provides, that they've got to somehow find access to, and it makes, I think, life much more difficult for them. We've estimated that we think, based on this budget of the $36 million from the county plus the $64 million from the federal government, that we could cover somewhere in the neighborhood of 26,000 people. Now, once we we'll have a better sense of that, I think, once we get the benefit package agreed on, then we can cost it out and see how much, you know, how many people we can cover through that program. So it's a fairly, you know, it's kind of an organic process. There's not sort of definite dates or deadlines. But Ohio, I mean, this is not unique in Ohio. We've done lots of Medicaid waivers in Ohio. I don't know if folks are familiar with the Passport program. That is, in fact, a Medicaid waiver that has been in existence for many, many years, actually since George Voinovich was the person who originated it when he was governor. So it's not new. A lot of other states have done Medicaid waivers for different kinds of groups. The state of California did a waiver very similar to this, and they're now up in operations, I think, in about 8 counties in California. So it's not a new thing. It's new here, and it would represent, if we're able to do it, the most significant expansion of coverage to the uninsured in this community in a very long time, actually. So we think we're excited about it and are sort of moving all speed ahead. Mark keeps telling me it's priority number 1, so that's what we're working on.
Questions on this proposal? Councilwoman Simon, and then Councilman Rogers, and then Councilman Strawn.
Thank you, Mr. Chair. To Mr. Corlett, I understand this is a new waiver program,
Right.
but there's been other waiver programs to which other states have taken advantage
Correct.
of. Why in the past hasn't Metro taken advantage of other opportunities to get a waiver?
That's a really good question. Prior to the Affordable Care Act being passed, the only way you could expand coverage to a newly eligible group was to show it had to be cost neutral to the federal government. They couldn't spend any more than they did today, which made it very difficult to add large numbers of newly covered people to a program, because you're adding all this cost, how could you show that you're going to spend the same amount? And so that was difficult, I think, prior to the Affordable Care Act. The Affordable Care Act said, we're changing the rules. If you want to cover this newly eligible Medicaid population through a waiver, it no longer has to be cost neutral. The federal government recognizes that they will have to spend more money to cover this population. So it changed the rules on it, and it opened up a possibility to us that didn't exist. The other thing I should point out is Metro Health, as a public hospital, is uniquely qualified to do this, because only a public entity can put up match for the Medicaid program. So a private hospital can't do this, a private charity can't do this. You can do it with public funds through a public hospital.
Thank you. Councilman Rogers.
Thank you, Mr. Chair. To Mr. Corlett, will patients only be eligible to participate in the waiver program if they come through Metro?
The question is, that's a good question, actually. One of our objectives in this waiver is to provide the majority of the care through Metro Health. One of the things, the federal government is really interested in 2 pieces here. They're interested in the coverage expansion, but they're also interested in transforming the way we provide care. And so when Mark spoke earlier about the Partners in Care, the medical home, that's kind of the other half of this proposal. So we want to make sure that their primary care is delivered in a medical home, and all of our primary care sites will be NCQA accredited next year as medical homes. Now, the other part of that is there are some services that would likely be provided outside of Metro Health. For example, if someone has this, I'll say this Metro Health waiver card, and has to go to an emergency room, we're not going to say you all have to come to Metro Health. You want to go to the place that's closest where you can get services, and then we would pay for that care to that person who provided that care. The other thing that we've thought about is, we're looking for ways to involve the federally qualified health centers, I always call them Huff Norwood, Neon, Neighborhood Family Practice, Care Alliance. And then I also think there are implications on the behavioral health care side as well, because this would be a newly covered group. These are adults for the most part, today, who've never really gotten coverage before. These childless adults who've never been able to qualify for a program like this before. So we would aim to provide most of the care within Metro Health so that we can have them all in our medical home, and also be able to track all of them through the electronic health record that we have.
Mr. Chair, a follow-up to that.
Yes, Mr. Rogers.
So once Cuyahoga County is, or the state does their work, and these hopefully 26,000 new people are able to be covered under this new program, how will the people be notified? Are we talking about specific people, or do we see, based on the eligibility criteria, that it's going to identify a specific set of 26,000 people, or is this kind of a broad category and first come, first serve? who comes in the door will be eligible for this, to participate in this?
That's a very good question. We've thought about it in two different ways. One is, because people come to us now who are uninsured and we qualify them for a program called HCAP, the Hospital Care Assurance Program, we collect a lot of income and eligibility information from people. And so one of the things we've talked about with the state is, rather than having people to go through a whole other application process, that we would do almost what we call an ex parte determination. We say, we have this information in our possession that shows what your income is, all that stuff, and we would make them eligible, put them onto the program by administrative action, so that people don't have to go through another enrollment process. But I would also think that we'd have to do some public awareness work, that we'd have to let people know, educate people around. I think we'd also want to work closely with the Department of Employment and Family Services here at the county, because they see people all the time who don't qualify for Medicaid. And so we'd want to have a way, I think, to accept referrals. I mean, we do have a set amount of money, and so it's not an entitlement like Medicaid. This program will be capped based on the amount of money we have. But we've talked about first trying to take the information we already have in our possession about people to get them onto the program. But then I think from there, we'd work with some of those community partners I described earlier, and with Employment and Family Services, to make sure that because we want to make sure we access the waiver fully. We want to make sure that we utilize all those funds.
And just the final question. So if the county puts up $36 million in anticipation of this program moving forward, there's nothing to necessarily say that the benefit from people being a part of this program will necessarily go directly to Metro. Because if you qualify for the program, you could be a patient of the clinic or UH, for example. Is that correct?
They could be patients at those institutions, but I think we would ask them, if they're funded, if these services are funded through the waiver, through the Medicaid waiver, that we would ask them to get the bulk of their services at Metro Health, because we want to make sure that they're getting that care is provided in a way that's consistent with the medical home program that we've outlined. There are probably always going to be services there may be services that we can't provide. I mean, we know that today, and so those services would be things that we refer out from. But if it's something that we can provide, I think we'd want to provide it within Metro Health, so that we have a complete picture of what's going on with those individuals. Because we'll be responsible to some extent, for their health outcomes, and there's other information that we'll have to report to the federal government. So we want to be able to make sure that we've got sort of control over the situation, so if we're going to be held accountable for it, that we're delivering the care. So.
Follow up?
Is there any way that we can mandate that they have to go through? I mean, if it's for services that you can provide, and essentially you guys are doing the work, we're providing the match amount. It seems like it's in our best interest that we make sure those patients go through Metro Health as opposed to other facilities.
Yes. One of the waivers that we would be seeking, there's a waiver, a provision within Medicaid called freedom of choice, and it's a waiver similar to what the federal government granted to the state of California, saying largely that these services have to be provided by a certain group or number of providers. So yes, you can. That's part of the waiver process, is to describe how you would do that.
Okay, thank you, Councilman Rogers. Councilman Sean.
Thank you, Mr. Chairman. Mr. Corlett, is this a one-time waiver that we're looking at for just this biennial period of time, or is it something we're anticipating going forward on a reoccurring basis?
I mean, I think at this point we've talked about a waiver that takes us up to 2014, because 2014 is when really the coverage expansions, which are in the healthcare reform law, the Affordable Care Act, take effect. So this would be up to 2014. It would be our anticipation at that point that these folks would then move on to the Medicaid program, the state Medicaid program.
But, so therefore it's annual, the $64 million?
In terms of, we have to go back every year and have it re-upped, or?
No, assuming you're successful, it's a matching, whatever you receive matching from the county, you're going to get a $64 million match every year until 2014. Is that?
Well, it's based on how much money you spend. So I mean, you've got to provide $36 million worth of medical care in order to pull down the federal match. So you'd have to So it's not exactly like we get it approved and they send us a check for $64 million. It's really, you've got to provide that level of care, that $36 million worth of services, in order to earn the match from the federal government.
Okay, and so that's, you indicated it likely would not kick in until third quarter for
Right.
budgeting purposes?
Right.
Is that correct?
That's correct.
So the funds would not be eligible until third quarter?
That's correct. That's correct. Until
When do we
have the
start
waiver
spending
approved.
money to support this, this program?
I mean, to support, I mean, we would not.
To gear up, to have your facilities ready to absorb 26,000 more patients. We were told at a previous hearing that if, with the Med Select, that we're only going to potentially absorb 1,000 more people out of our county program.
Right.
Now we're being told 1,000 plus another 26,000. At what point do we start to gear up our expense side, which also is not in this budget? At what point do we start to gear up the expense side?
Well, Councilman and Mr. Chairman, one thing to remember is that we actually serve a lot of these people today. I mean, of that number, we serve, I think roughly about, I think we figured about 14,000 who are below 100% of the federal poverty level, who are uninsured today. And then we serve another number who come to us primarily through the emergency department or the inpatient side of the hospital. And it's really that latter population that I think where we can show the most benefit by focusing on them. But I think, demand will drive, what we have to do in terms of our capacity. If we see capacity, demand exploding, that somehow these folks are demanding or asking or obtaining new services that they didn't obtain before within Metro Health, then we'd have to adjust capacity. There will almost certainly be requirements in the waiver from the federal government to guarantee a certain level of access. That's part of the Medicaid program today, that you've got to be able to guarantee a certain level of access to people. So that's one of the things we'll have to work out with them to find out kind of what that is, and that may be where we also work with these community partners, because I mentioned the federally qualified health centers, the FQHCs. One of the things we want to look at is, of their patients that they have who are uninsured, how many of them are already our patients? Neighborhood family practice has about 3,000 uninsured patients. How many of them come to Metro as well to get maybe their subspecialty care or things like that? So that's some of what we'll have to do to be able to figure out that demand question.
Well, you indicated just a few minutes ago you had all this data, so that's why I'm concerned as to why we don't know exactly how many of the 26,000 are part of the data pool and how many are new coming out of that 26,000, and at what point do we start to add expense, which is not in this budget?
Right, but I guess I was trying to get to the point of those 26, of those people that the ones we already know about who already get their primary care from Metro, plus those additional, those who come through the ED or who come through our inpatient side. I think we want to look and see how many of those are being served for their primary care at a neighborhood family practice or maybe a care alliance, because that's who we might work with then. Maybe they keep getting their primary care services there rather than coming through Metro, because, for example, neighborhood family practice is also pursuing accreditation as a medical home. So they'd have that sort of care transformation piece as well as the coverage piece. So some of this will get worked out as we work out the waiver and see what we're required to do, because waivers are a process of negotiation. It's really hard at the beginning to say, these are all the things we have to do until we've had more conversations with the federal government and the state government about it.
No, I guess I never saw. I'm not understanding how the budget's being built at this point in time. We've got slides talking about anticipatory $64 million, but I don't see the corresponding slides of the anticipatory expense. So.
Okay.
Councilman Miller.
Mr. Chairman, to Mr. Corlett, you're probably going to say this is a lousy question, but a negotiation is not always successful, and with the number of moving parts we have on this, there's some possibility that a waiver would not be granted, and if a waiver were not granted, or let's say it were delayed a year and we didn't get the extra $64 million into the Metro system, how would that impact your financial situation And what would be your alternative way of spending the $36 million subsidy?
Mark, if you want to.
Mr. Chairman, I think we would spend the $36 million largely the same way we've already spent it. And I can refer you back to page 10, where you see that the $36 million is going to deliver $130.9 million worth of uncompensated care. I think that will continue to be our policy. It will continue to supplement what Metro Health invests from its margins and the Ohio HCAP program. And I guess, maybe to hopefully put Mr. Schron's mind to rest on this, we did not feel we were at a point in the definition of the benefit structure to actually put the revenue side of this in place in our 2012 plan. And I think that there are a fair number of the 26,000 people that we're covering today, and that is in the cost side of the plan. So for us, we're seeing the waiver as an opportunity to improve our revenue production and improve our ability to give access to more people that we believe are out there that are not getting care. But we're not at the point where we can give you exact numbers about how much comes from people we serve today and how much comes from people we have yet to serve. That's work that's still going to have to be done in the course of building the waiver application and building, if you will, we're going to take our 2012 budget and then we're going to lay in another, basically another page of the budget that says when the waiver kicks in, here's what happens to the cost side, here's what happens to the revenue side. And of course, we'll bring that back to you and show you where that comes out. But that is a non-trivial exercise to do that budgeting. We're in a new world here, and we're going to need some high-powered operations and finance analysis to really understand what that's going to take.
Mr. Chairman, follow up?
Yes.
Mr. Chairman, to Mr. Moran, since you said that the revenue and expense from the waiver is not yet factored into the 2012 budget, my question is, if it were to be factored in, would it improve the $12 million operating surplus that you're hoping to obtain? And if so, by how much could it improve that on an annual basis?
Well, again, it would be speculative of me. Page 16 shows how we're thinking about 2012 with a $10 million operating income. Were we to get the entire $64 million for the entire year, you could just add the $64 million to the net patient revenue, and if it were people we were completely serving today, the 64 would drop to the bottom line. That, frankly, is unimaginable to me because there's more service to be provided and there's more people that need service. Our goal is to make that $10 million run at an operating margin of 4%. If we can do 4%, we can maintain our bond rating and we can reinvest in the system. So our goal is to see provide as much service as we possibly can and reach 4% operating margin. Obviously, we're not there. We're not even there with the 10 million. But that's our goal.
Okay.
Thank you.
Councilman Greenspan.
Thank you, Mr. Chairman. And I don't know to whom to ask the question, so I'll ask the question, and either of you can answer. am I to understand that the $36 million subsidy will then be, the $64 million will be added to that, so we're talking about $100 million impact, is that correct?
Yeah, that's correct, Councilman Greenspan.
All right, and that's one question. So the 26,000 uninsured adults, those are not unique visits. In your 218,000 or 217,000 visits, those 26,000 individuals may have multiple visits, which would add to that, correct?
That's correct.
Okay. When Mr. Moran, when we met to go over this appropriations request a few months ago, I think in August, we discussed this program, which I support, and I hope that the county does or is successful in receiving this waiver and these funds. But I also asked the question if you would not have an objection to us conditioning the $36 million to the application towards this program, and you said no at that time. Is that still your answer today, that if we were to appropriate the $36 million, which I would support, but that it specifically be leveraged for this program? Obviously, if the county was unsuccessful in receiving the waiver, then the money would still be available to you, but for indigent care. And that's where I'm trying to put the emphasis, is that the funds are used for indigent care only.
The funds are used to provide care to those who can't pay for their own care. All the 36 million is used that way today. All that will be used in the future with the waiver or without the waiver. I will commit to that.
Okay, so just to follow up on that point, so if we were to condition those funds to be used for indigent or charity care, there would be no concerns from you on that? Okay, very good. Those are my. Can I ask one more question?
If it's on this subject, it's fine.
Yes, sir. I just want to be respectful of the chair. The HCAP, is HCAP going away? So the money that we received, the $26.9 million, is that, are we choosing one program over another?
Mr. Chairman, Councilman Greenspan, it would ultimately go away more as part of the federal health care reform law, because under health care reform, what's called the disproportionate share hospital program is reduced dramatically starting in 2014, but the reductions really pick up in 15 and 16. The way HCAP is calculated, there's a 2-year delay. So we're operating this waiver in 2013, our HCAP allocation would actually be based on what we saw in 2011. So there's a 2-year delay. So we wouldn't, the loss in HCAP funds would happen later, probably at the same time that there are presumed to be federal cuts to the HCAP program already.
So, Mr. Chair, just a follow-up. So we can expect the same 26.9 next year in 2012 in addition to the 64?
Well, HCAP is calculated on an annual basis, and it is a formula that is known only to a select group within the Medicaid office. I don't think they ever told me what it was when I was the director. But so it varies from year to year. The one thing that'll be different next year, Metro Health is the largest HCAP recipient in the state. We're the largest disproportionate share hospital. One of the second largest ones in Cuyahoga County was Huron Road Hospital. So with Huron Road's closure, next year they take the money that went to Huron Road and divide it up among the remaining hospitals in Cuyahoga County. So it'll bump up a little bit next year, but it's really there's a formula, that calculations that are done every year to set that amount.
Okay, all right, very good. I have other questions, but not on this subject.
Thank you, Councilman. Mr. Corlett, I know this is, obviously, everybody knows that this Affordable Care Act is fresh off the presses, so to speak. Can you point to any other places, any other communities, either in Ohio or outside Ohio, where they're on the sort of the same timeline you are, looking to see how many, if we're all by ourselves or nearly all by ourselves, or there's a whole lot of us? Or
Mr. Chairman, I think probably the best way to describe it is we are nearly all by ourselves. The state of California was actually the first state to submit a waiver. They actually submitted a waiver statewide and allowed any county in the state to opt into it. And that is because in California, counties have a obligation by law to provide healthcare services to the uninsured. So a lot of counties put up money for healthcare. In Ohio, we're unique in that we have a Health and Human Services levy, that supports Metro. There are other parts of the state who have healthcare levies, but they're not nearly as robust, and they also don't have the same level of disproportionate care that we do. So we're unique in that way too. But I mean, California's waiver was approved well over a year ago. There are now, I think, 8 or 9 counties that are up and operating their waivers, and so there's a lot of interest, I think, at the federal level to try and pull that coverage expansion forward to make it happen earlier than 2014.
Just a follow-up to that, do you know how much success the other communities, including the state of California, have had in terms of having their waivers granted?
Mr. Chairman.
The state does it in California.
Yeah, Mr. Chairman, in California, their waiver was granted, and so those counties that chose to do it are moving forward with making their waivers operational.
So I guess it would be fair to say that the combination of the Health and Human Service levy, the fact that we have a public hospital, and the fact that the county supports the public hospital, along with the Affordable Care Act, all come together to give us this unique opportunity to expand health care here in Cuyahoga County and Greater Cleveland.
Exactly right.
All right, very good. Any other questions about the proposal? Can always come back to it.
I'm not going to.
Okay, thank you very much, John Corlett. Now, other questions? Councilman Greenspan.
Okay, great, thank you. Recently, the system announced a reduction in staff and a pay freeze for non-bargaining unit employees. And I'm just curious if, and this happens from time to time in the private sector, where senior management defers their compensation above and beyond any pay freeze in an effort to demonstrate a willingness to move the organization forward, at least to defer until, not a forgiveness, but a deferral until cash flow and profitability occurs. Have those discussions happened at Metro Health with the top tier executives or management to defer their compensation or portion, not entirely, but portions of their compensation to help through these tough economic times?
Councilman, we have, as you know, we study executive compensation regularly, and we do everything in our power to keep it in line. We have not paid bonuses this year, and beyond that, I did not feel it appropriate to actually reduce executive comp at this time. Our challenge in the environment that we face and with the complexity of our health system is to continue to improve the caliber of the top management of the system. And I can only do that if I can pay competitive salaries. And we are barely at that stage, but and so I feel I need to stay in that range right now.
Okay. That's your decision. I have been in environments where we've had to take, as executives, reduce compensation in order to help an entity through tough times. I would just recommend, if the situation continues, that's something you might want to consider. To follow on Councilman Gallagher's statements regarding the ambulatory growth plans, and the confusion he's speaking of is confusion that I share as well. And I owe Ms. Hill an apology. I told her it was on page 3. It was on page 2 of the August 24th board minutes, which and I have the quote here, but it talked about the ambulatory network expansion in 2014 and that there were no plans this year, in 2011. And your chief administrative officer echoed the same thing. So the expectation presented to this body was that there was no expansion. I have no problems with expansion, understanding that you have to focus on revenue generating opportunities. Right. But I'm just concerned and confused about the contradiction there. And can you maybe address that further as to, I know you tried earlier, but it was clearly defined in your report on the August 24th minutes, which were approved at the September meeting.
Yeah, Ann showed me the minutes earlier today, and I looked at them, and I think it talked about us expanding the ambulatory network for 2014. 2014 is an important point in time for us because the Affordable Care Act comes into play, and we have to be ready for a set of people who are going to get coverage. And those people are going to want coverage in a broader ambulatory network than we have today because of the rise of the poor in the outlying counties. I think that those minutes were worded in a confusing way, but since the beginning of 2009, I have been hammering on our organization that we must have a better distributed ambulatory network, that we have to have ambulatory centers that are multi-specialty, and that we have to be able to serve the whole county in time for 2014. And so I apologize for the confusing wording of that. Sometimes these things slip by me, but I don't think, there certainly hasn't been any equivocation or confusion in my mind that we've got to get on with it. We borrowed a lot of money to get it done. We've developed a prototype. We've looked at the land. It's time to march on with this one.
Yeah, as I said, you have to improve that. I'm preaching to the choir here. You need to improve that revenue enhancing model in order to support your mission to charity care. I understand I have one question on my on the chair's 3-question rule. Then I have some others. But one of the things that obviously is of great concern when you go through an environment that the hospital is going through right now is employee morale and retention. And last month, or when you were here a few months ago, I raised a concern about a 40% attrition rate over 4 years at the hospital. What are your plans to improve or at least get the pulse on employee morale and to retain those employees through these times? Because I'm hearing, and I'm sure my colleagues are hearing as well, that there's a significant issue brewing with morale, as would be expected in whether it's Metro Health or a private sector business during the challenges you're facing. And I just want to know how you plan on addressing those.
I think, first of all, when we did the analysis of the 40% number, it seemed that was adding attrition over multiple years. We have attrition rates that are in the 6 to 7% range year over year, and actually compare pretty favorably to other institutions in our industry. Notwithstanding that, you're right about the morale issue, and it's particularly difficult when there is a layoff such as we just went through last year to actually maintain employee morale. I think it's incumbent upon me, it's incumbent upon all the rest of the leadership to get out there and to let people know that we did this in a way that continues to be able to deliver our mission. We're a vibrant organization. We're continuing to recruit physicians and other providers because we will always need them. And the challenge is to be able to do the challenge is to be able to deliver the care in a much more efficient way. And that is an imperative that faces every single hospital in the country right now. It's the most dynamic industry that we've got, and it can really be difficult to recognize that in their industry there's a lot of turmoil. There's major shifts from inpatient to outpatient. There's major shifts in what you do in the inpatient side. Virtually every person's job in the system is evolving, and that makes it very difficult. That's a job for leadership, though, to continue to work with people to have them understand where we're going. Because people's morale is depending upon knowing what the vision is, where we're going, how we're going to get there, and that they'll be with us when we get there. And I think we've got a program, the services we're offering. The waiver is certainly an important part of improving the top line. The new ambulatory centers, and the master plan for the campus are all things that are very much about the future of Metro Health. It's a future that helps morale improve.
Any follow-up on your third question? Okay, thank you, Councilman. Councilman Sean.
Thank you, Mr. Chairman. And I do applaud the creative way of trying to identify the $64 million. Congratulations. My concern is that this is a one-time transaction potentially out there. And granted, one time with $64 million is still a nice benefit to pick up. But your comments were that you want to make sure you're looking at the entire healthcare system in the area. And my concern is whether we are truly looking at that here when you start looking at one-time payments. What is the utilization in the system right now of all of our facilities? And that doesn't mean just your facility. It means when you said the entire healthcare system, I truly took your comment to mean everything that's available in Cuyahoga County. That you were looking at the healthcare system.
I actually don't worry too much about Cleveland Clinic and University Hospitals. They seem to do well themselves. But let me say, Councilman, that the $64 million, as soon as we can get it, it's available for 2012 and 2013, and that essentially is pulling forward benefits that will get to us in 2014. So we expect those benefits to be part of the Affordable Care Act when we get to 2014. So more than a one-time transaction, that is actually a kick-up in eligibility, a kick-up in revenue for the Metro Health system that we expect to last in perpetuity. And we will put it in the budget as we get to more clarity about timing and the specifics of the benefit package and what the demands it makes on us. I think your question about capacity utilization at the Metro Health system, I can answer pretty clearly and categorically. We have actually fairly high physician utilization. There is more we can do. We've actually done a lot. Each of our CCH centers has raised its productivity between 7 and 20% over the last year alone. The ED has raised its productivity probably 25% over the last 3 years. So we're utilizing our human capacity pretty efficiently, and that's capacity we can add to as we need to. Our physical capacity, we have excess capacity in the ambulatory centers. Those ambulatory centers are probably operating between 50 and 70% of their capacity, so we could add a significant amount more primary care in those areas. The challenge that we face is that they are just primary care centers, and we really need to add more imaging and specialty, which will require bricks and mortar. That's why I'm so enthusiastic about investing in the ambulatory network. The main campus is rated, our certificate of need and our cost report rates us at 750 beds. You can see from the chart we're regularly running an average census around 400 beds. The place where we are most capacity constrained is in the ED. We've added rooms to the ED. We took waiting space and turned it into additional exam rooms this year because we were taking care of them so fast. We need the exam rooms more than we need the waiting rooms. And we added Metro Express, which is an urgent care capability in Broadway and in West Park. So we're managing capacity. Our surgical capacity is actually quite good. We're operating 17 of the 20 operating rooms on the main campus, basically 12 hours a day, and we have the 4 operating rooms at our West Side Ambulatory Center that are operating probably 60% capacity. I can get you the details on capacity utilization. We have spare capacity at this time.
Do you have a percentage for that? Just
long as you mention it.
It's hard, I've got apples, oranges, and pears and everything, so I have to look at it. Surgery, we're operating probably 60 to 70% capacity. In the CCH sites, we're operating at probably 60% facility capacity, 85% physician capacity. And then the main hospital, whatever 400 divided by 750 is, I can't kind of do that in my head, but.
A little over 50%, someplace there.
Thank you.
Yeah, something like that. I know you indicated you weren't worried about the other facilities here in town, which I defined as part of our healthcare system. We as a county, our second largest expenditure beyond the personnel is healthcare to those other facilities. So we have we as a body have a vested interest in making sure we understand how we spend our healthcare dollars out here. So I guess I would challenge that your assertion that I know you don't worry about it, but as you open up all these.
I do, sir, because we believe strongly in Metro Select, which is a program to get county employees into a Metro-only insurance plan, which we believe has saved the county a lot of money. So I understand, I do feel it strongly because our benefits are actually the second largest expenditure we have at the health system as well. And so believe me, I'm completely in sync with you on that.
My concern is when the healthcare system starts operating what would appear to be a third set of competitive products out there in these satellite operations, because these other two facilities have their satellites out there, and now we're opening up what would amount to what sounds to be in this budget and continuing budgets, a series of ones, because that's where you see your growth. What concerns do we have when that competition starts to put pressure, additional pressure on these bricks and mortars that you're asking us to open up?
Well, I think for us, the imperative is to find a lower cost way of serving patients, and serving patients in ambulatory centers that are developed to be ambulatory centers is much lower cost way for the Metro Health system to serve its patients. So even if we didn't get an additional patient along the way, we still would have to be making this move towards a more ambulatory, lower cost way of delivering care. That's a long-term imperative in the delivery of health care. At the same time, we do want to grow. We would like to expand. We would like to be able to serve patients conveniently, accessibly, and that probably will cause some competition. Competition generally turns out to be better for consumers, lower cost for consumers, and I think that because it's going to be better for patients, that's what's motivating us. My colleagues at the other systems, I think, let me not say that, okay?
And is there anything in this budget?
We all should take into account the impact on each other as we think about our systems.
And that's where I was going with your creation of a whole new set of satellites as a follow-up on your comment. Does that take that?
Mr. Sharon, if I didn't have to take care of the lion's share of the uninsured in this town, then I wouldn't have to do this.
The last capital expenditure item was, you alluded that the core hospital is in significant disrepair and is outweighed its useful. Major portions, I thought, had outweighed its usefulness. I thought it was your terms.
We did.
At what point do we start to have to factor in a capital budget for this item? And is there capital planning budgets in this budget right now, in any of these numbers, to do forecasting and expansion and things of that nature, with a target of some
I assume, multi-millions of dollars to rebuild that facility.
First of all, let me make sure I leave you with a correct impression. Last year we did an engineering study with a firm by the name of VFA, who did a kind of top to bottom review of every facility on our main campus and on our Deaconess campus, roofs, structures, electrical, plumbing, and we have a detailed understanding of where our system is. The main conclusions that they gave us were that about 65% of our facilities are beyond their useful life, and they also told us that if you were going to reinvest in these facilities, you would need to invest $450 million to bring those facilities up to their original functionality. So that's a little bit like investing in to bring a 52 Buick up to its original functionality. It doesn't even bring it to 2012. We're going through the process, the master planning process right now. This budget does not include any capital expenditures for main campus. It anticipates a $40 million expenditure next year, mostly for renewal. The additional $23 million for Middleburg Heights will be in addition to that $40 million. And we will soon bring to the board a long-range capital plan that will go out to 2020. And as soon as we have the board's authorization, we'll bring that back to you for some understanding of that. We've been through a few initial sessions. It's challenging, and it's something that we'll want to discuss with you in detail.
Councilman Miller, then Councilman Simon again.
Mr. Chairman, to Mr. Moran, on page 11 of the document, it says that we have an operating income of 1.4 million. It appears to be a September year-to-date number, and on page 17 of the document, there is a projection. I don't think it's
16?
I'm sorry, on page 16, there is a projection of a 6.3 million operating loss, which appears to be a full year estimate. My question is, does this mean that Metro is expected to lose $7.8 million on an operating basis in the fourth quarter, or am I comparing apples to oranges?
No, it's a very good question, Mr. Miller. We gave you a projection in the summer, which is on page 16, where we took the first, I believe this was through August, or maybe through July, and we said what could happen if the first half's results or first 7 months' result rolled out to the remainder of the year. In July, at that time, I put a hiring freeze into place, and we began controls on discretionary spending, and we began to really clamp down on a lot of our spending, so that the months of August and September really are not taken into account in this projection. I didn't want to update the projection, but you do see the August and September actual results on page 11. So I would say that our August and September results were more favorable than we expected. And I do not expect to lose $7.8 million in the fourth quarter of the year, but at the same time, we're being extremely careful. Our goal is to break even for the year at the operating line, and we're challenged to do that. So I thought it was premature to do any kind of fourth quarter projection. We're working on the October numbers right now. We'll know those probably later this week. And, it's important to recognize in healthcare, November and December are generally pretty slow months. It's harder to control costs in those months, and particularly for us, we're fairly sensitive to the trauma season, which is a May through September phenomenon. So we're just trying to control costs through the fourth quarter.
Mr. Chairman. Mr. Chairman, Mr. Moran, you testified that you were going to spend about $35 to $40 million in capital this year and an equivalent number next year. Yet only showing basically break even for this year and maybe 10 million plus for next year. My question is if you could describe how the capital expenditures are being funded. Where are we in terms of perhaps using an existing bond issue, and how much capacity is there to sustain that level of expenditure on an ongoing basis, and it doesn't even seem to include major needs in the future like the main campus?
Mr. Miller, that's a very good question. So let me just try and set your sense and the council's sense. Our operations fund capital in the following way. We have depreciation expenses, which are non-cash expenses of about $30 million a year. So a $30 million depreciation plus a $10 million operating surplus generates $40 million in cash that can be reinvested in the system. So that's kind of my equilibrium. We need 40 million reinvestment just to keep up with the technology need. We aren't even keeping up with the technology needs for clinical equipment, for particularly for IS, and then to keep the buildings fixed. Since I started in 2008, we have generated a significant amount of cash from operations through the efficiency improvements we've made. In fact, we've put between the Build America bonds, which are restricted, and the operating surpluses we've run, we've actually put about $110 million of cash onto the balance sheet. And part of that, I actually reduced our capital spending in 8, 9, and 10 below that $40 million level. So at this point, we're catching up. And so I think the story is that I want to get us back to an equilibrium rate of $40 million spent on capital to renew the technology and the facilities that we have. And then the Build America bonds will go to fund the development of the new ambulatory centers along the way. We will need to improve our operating margins to be able to support an investment in a new main campus. But even in the best case operating model that we have so far, and still early, we will need to find some additional source of funds to reinvest in the system. And I'm thinking of that as a 2015, 16, 17, and beyond kind of spending. But again, too early to come to you with that kind of capital request, but we will come to you with it.
Okay, thank you.
Councilwoman Simon.
Thank you, Mr. Chair. To Mr. Moran, this may seem like an unusual question to you, but to my colleagues, I don't think they're going to be overly surprised that I continue to ask questions about ethical issues. And I understand that Dr. White was housed in your hospital doing his experiments that at the very least were controversial. And I wanted to know if you have any labs now set up that have primates that are being experimented on. Dogs, cats, primates.
I believe we do have labs in our research building, yes.
Primates?
I'm not sure of that.
Does anybody know if there's primates at Metro Hospital?
I'm not aware of any primate research.
No.
Dogs or cats?
Would you please identify yourself?
That's Dr. Connors, the Chief Medical Officer of the Metro Health System.
Thank you.
I would like to get back to you on that with the specifics.
The reason for my question is if this council person is gonna look at subsidizing Metro with a subsidy and perhaps be looking at capital improvements and other brick and mortar questions, I want to see, ethically what's happening with the lab. And so if you can get back to me, I'd appreciate that. Will help inform my vote. Okay.
So how soon can you get back to the councilwoman with some information? I'm sorry, I was speaking too quickly. How soon can you get back to the councilwoman with some specific information that she's asking for?
I would think within the next few days.
Yeah.
All right. Okay. Thank you.
How about a week? Can we? Okay.
Councilman Jones.
Thank you, Mr. Chairman. Mr. Moran, I've talked to several long-term skilled facility directors, owners, and they've always articulated to me the difficult times they're now facing because they're funding through, when it's predominantly Medicaid and those long-term care reimbursements, they've really been cut, and it's a challenge just to stay in this business. I see that our recovery action is to consolidate the long-term care. Can you tell me how many bids did we have, and what was it break even or loss? Small margin, profit margin? What was the numbers?
We, at the beginning of 2011, we had approximately 300 beds filled, maybe 295, but in the 295 to 300 range. And that was at capacity. We were running at our full capacity, using every bed, essentially. We lost approximately $5.5 million in that business last year, and we're losing $6.5 to $7 million in that business this year. And we really took a hard look at it and said, first of all, those kind of losses really do jeopardize our ability to do the other aspects of the Metro Health mission. It is not, long-term care is not our core business. And we looked outside in the community, and we saw many providers in the community who had excess capacity, additional capacity, and could take these patients. And so we looked at it. We looked at all of those factors and said we're going to reduce our capacity by 144 beds. We are, which will leave us with 150 beds. We are moving, or we're consolidating part of the old Brooklyn facility into the Prentice facility, which is a much more efficient way of serving those 150 beds. So in a sense, we're counting on some operational improvements through this consolidation. And then we're taking great pains to make sure that the patients who are being displaced get their choice of which of the centers in the community they choose to go to, and we're helping them with that choice. At this point, we have discharged about 74 patients, but about 75 patients. A third of those patients have gone back to home, and I think that is consistent with the state Medicaid guidelines and direction and how they want their policies to be implemented of moving more towards home-based care. Of the remaining two-thirds, probably 40% have gone to a nursing home that has a Metro Health doc as a medical director, and probably 60% to other facilities, but other facilities that those families have chosen.
Have you projected what that consolidation, what your profit loss will be in 2012 for the long-term care?
Yes,
as you consolidate?
we'll still lose about $4 million in that business
After you've completed your full consolidation?
after we've completed the consolidation. There's a significant mission component to the skilled nursing and long-term care business, and we find there are a number of patients who would have a difficult time being discharged into a private, not-for-profit nursing home. And so we're trying to maintain the capacity in order to take care of that group. Now, that group is less than 150 beds, but we are trying to, through the consolidation, we're trying to stabilize that business.
Thank you.
Councilman Greenspan.
Thank you. I'll wrap it up with these questions. Just a general statement that somewhat infuriates me every time I hear this being said. And you made the statement that Metro provides a lion's share of indigent care. Based on numbers that you've even provided between Metro UH and the clinic on outpatient discharges from 2009, you provided only 23%, and the other two institutions had the bulk, the difference. As a matter of fact, based on those numbers, the clinic served more in indigent care outpatient discharges than Metro saw in total patients by almost 9%. So I don't devalue, and I actually value and draw attention to the job you do, and you do more as in relationship to your total patient load than the other hospitals. And if that's the perspective, that's fine, but there's a third party that provided validation on charity care dollars spent, uncompensated care, and Metro provided between the three facilities less than 10% of the total uncompensated care between the three facilities. So once again, I don't devalue what you're doing, but be careful with the words you use, and that's basically my statement on that. The $64 million.
Second. Would you like to respond to the councilman's comment?
Well, Mr. Chairman, thank you. I think I don't want to infuriate you, and so let me.
No, it's not. It's just when those
careful.
statements are made.
I understand. When we came to you in May, we had a chart that showed that between our Medicaid and our uninsured, and I think it was a chart on inpatient discharges, because outpatient is actually pretty hard to come by.
That's correct. It was inpatient. That's
and on inpatient discharges, we grouped Medicaid and uninsured, and what you saw was, because the Cleveland Clinic system is, of course, vast, and they do a lot of Medicaid. When you consolidate across all of their facilities, they do more Medicaid business than we do. And I'm not trying to devalue what anyone else in the system that Mr. Schron has framed this discussion with. I think it's important, though, to recognize that Medicaid is a form of insurance. And when you take Medicaid away, there's a whole group of patients that basically have a hard time getting access to care. And I think it is worth the exercise to go get the numbers. It is not an easy thing to do. The numbers that you saw are actually quite dated because, and they came from the Ohio Department of Jobs and Family Services. But I think, we will go and get the real numbers and come back and have a discussion about the real numbers. I don't know what the third-party group is that said we do 10%, but obviously.
It was Congressman Kucinich's numbers.
Okay, well.
That's okay.
I'm happy to challenge Congressman Kucinich's numbers.
Okay. Thank you. May I the $64 million, is that one time over 2 years? There's $64 million over 2 years. So 64 plus 64?
It has the potential for the 36 million matches to 64. So as soon as we get the waiver, the 36 matches to 64 year after year after year. Every time you apply 36, I think we have to be careful how we say this, but my view is every time you provide us with a 36 that can be put up for match, it will pull down the 64. So potentially 200 million in 12 and 13.
Okay, thank you. I have a question on the pending procurement policy that's going to be before your board. The no bid language, the sole source language, is not as strong as some other public organizations. And I'm just curious how the new policy will be different than the existing policy, and how some of those sole source contracts that were awarded in the past would be more fairly bid in the future.
Couple of things to say about that. First of all, the council and the executive have raised the bar on procurement of professional services, and so we're going to make every effort to bid as much as we possibly can. The language there was written in a way that the Metro Health system can bid as much as possible, but at the same time, if we have professional service firms that have served us well and their rates are the same, the scope is being defined by us, it's being managed by us, we have the opportunity to extend their work. That's all it's meant to do. It's also important to recognize that Ohio Revised Code 339, which is the law we always follow, says that these types of expenditures have to be put in front of the board and discussed by the board in open session, so that the level of transparency is much higher for us than for any other hospital system. What we are trying to do in that proposal is balance the needs of the hospital system in its competition with other hospital systems to maintain trade secret and other proprietary aspects of our delivery system, but at the same time be as fair about bidding as possible. And I think the proposal was meant for the board. It was accomplished after a fair bit of work over the last 6 months to make sure we were being smart about this. It was meant for the discussion of the board. I think it was wise for the chair to postpone the discussion because there was a lot of new material that came before the board, and I think it was wise for them all to read through all that material. So I think it's, the board will decide, and whatever the board tells me to do, I will do.
Okay, thank you.
Councilman Schwan, final question.
Yeah, only because of the numbers that came up in regards to the $36 million hopefully is not going to be in question from this council on both years. So what we're talking about drawing down is potentially up to 128 million. Is that
correct?
Is that correct? So it's not
2 years of 64. Potentially.
Right. That, to me, that was that.
Yes, I know
Okay.
that we kind of.
Yeah, I just wanted to make sure that what we're talking about is not our 36 million, if that's already in play. It's the additional amount. So it's not the $100,000 or $100 million each year. It's just the additive factor. Is that correct, Mr. Corlett? Yeah. And then my understanding of the 128 million, that there is potentially offset from the age cap, which has the ability to do a deduct at the same time. So I really would like to know what's the net amount that we're looking at. So we're all going to be, because I know what's going to happen. People are going to walk out of here, I believe, and say this is $100 million, how can we turn around from that? Well, let's make sure we all understand what the right number is. And so my understanding is it's going to come down as a result of the HCAP potential reduction. Is that?
Mr. Chairman, Councilman Schron, I think one of the things we learned after we had our conference, your questions to me actually made me go back and sort of ask about that. And I think what we determined was because HCAP is on a 2-year delay in terms of how their funding is calculated. I mean, your funding is based on, for us, the reason we get HCAP dollars the most in the state is because we're the hospital that serves the largest percentage of people below 100% of poverty who are uninsured. So, but when they make that calculation of how much we're going to get, they actually look 2 years back. So while the waiver is up actually and running, our HCAP actually shouldn't decline based on this. It will decline in the future, probably beginning potentially in 14 and 15, but it would not decline when we're in the middle of the waiver.
No, I understand it.
Okay.
Well, the timing is a sequencing timing, but it's dollars are fungible, at least last time I checked, and they might be falling in a different period. But what is the amount of deduct that we could anticipate in the subsequent years as a result of the decisions we're making today?
Yeah, I don't know that we would know that yet because, I mean, I think everybody anticipates, even when 2014 happens, is that there are still going to be people, even though they're eligible to get care or eligible to be covered, who won't be covered for whatever reason. So once we see, what our experience is with the uninsured, and actually what's happening to the other systems in the state, because with HCAP, it's a set amount of money, it's a fixed pot for the whole state. So it's not just what we do, it's what other people do as well that influences how that money is distributed.
Okay, I'm just coming back to that because I thought the number you had told me in our earlier conversation was as high as potentially $20 million per year, which is 40 out of 128. So the net effect would be realistically, not that $88 million is not a nice thing to have happen to you, but it's not $200 million that was alluded to.
Councilman, we're going to need to do a lot of modeling. This is unbelievably complex. I can't imagine how this guy learned all this stuff. And this truly is his brainchild. So I think Mr. Corlett deserves a lot of.
It's a great idea, and, when we spoke the last time, it looked as though it was going to be, of the 128 million, it was 40 million of that was potentially going to come off the top. So I just wanted the council members to realize that that $40 million was potentially not going to be out of that.
Let us come back to you with refined estimates, because we're going to need your support, and you're going to want to know how this is actually going to happen. You've asked a lot of good questions, and we got them, and we're going to be working this hard. As I told John, this is my number one issue, and I'm spending a quarter to a third of my time on this issue to try and get it to happen.
My concern is that there isn't a clawback some point along the way in one of these processes that they claw back 2, 3, 4 years later, which the governments sometimes have a tendency. Mr. Corlett will tell you, you would hate to have a clawback where you lose $40 million in 2 or 3 years down the road, and then they claw back and pull back monies out of another process, and all of a sudden now you really have a huge vacuum that's occurred.
Miller, final question.
Mr. Chairman, Mr. Moran, it's on the same point. It's in a best case scenario, since the waiver would not actually go into operation until the third quarter of 2012. What would be the best case scenario of how much of that $64 million that we could actually get in 2012?
Whatever benefit we would get would be based on the expenditures that we have. So if we had $36 million worth of expenditures for this covered population in the fourth quarter of the year, then you would generate the full 64. I mean, I think that's unlikely. I mean, I just think my experience in this would lead me to think that it would take some time to get people into this program and provide the services. But when you look at how much we're projecting to provide this year in charity care, I mean, $130 million to the uninsured. So, I mean, we provide a significant amount of care to this group. And so the question would be, could we provide that $36 million worth of care in the fourth quarter of next year?
And Mr. Chairman, does the federal coverage expansion go into effect on Jan 1, 2014, or is it some point during the year?
January 1st, 2014, you're correct.
Thank you.
Thank you. I think I have to tell you, Mr. Moran, that your endurance has been quite admirable. And we've had a lot of good questions, and because of the nature of this proposal, obviously we're going to be wanting to monitor this, as it goes along. But if there are no other questions by the committee, I think we're done with Metro today, and hopefully some of us will be around to help you celebrate your bicentennial. So thank you very much for your time.
Thank you.
The committee will take a break of 10 to 15 minutes, more or less, before we will come back to move on with today's budget hearings.